Well, thank you. My interesting talk is tomorrow on whether we can really afford all of these treatments and testing and MRD and everything else. But today I'm pinch hitting for Shaji Kumar, who is supposed to give this talk, but is chairing the ECOG meeting in my absence there. So I thank Mohammed for making the adjustment to the schedule. And the talk today is on how do we define smoldering multiple myeloma. Since I was a medical student, I've always been fascinated by how people define diseases. How does somebody come up with a disease, give it a name, and then embed it into the medical literature, and then it sustains? And I've been just very fortunate to work with Bob Kyle because he's given the roadmap for how you go about defining a disease. If you're going to establish a disease, how do you do that? And he's done it with MGUS, and he's done it with smoldering myeloma. And he's used the same principles, basically. You make an observation. You're really good at patient care. You're really good in science. You make an observation. He's found certain things in clinical practice. And then using that, he creates a name. When you have these things, I'm going to call it MGUS or smoldering. And he puts some very distinct criteria. This is how I'm going to define these. And then once he's made this arbitrary entity, he goes on to study it for the next 30 to 40 years. Basically look at the incidence, the prevalence, what is the natural history of something like this? If I define it this way, what happens to people? What are the risk factors? What's the prognosis? How do we manage this? You just study the whole thing systematically and you come up with this. And then you have to make refinements because you've learned something along the way, and then you say, well, what I initially set as criteria are not really that accurate. Now I need to adjust it, and he has adjusted it later. He's done it, and I've watched it firsthand with light chain smoldering multiple myeloma, with light chain MGUS, and with smoldering multiple myeloma. So it's really very fascinating. And so the talk I'm going to give is not just the work from Mayo, but it's work from so many of you and so many colleagues. I have no conflicts to disclose. The term smoldering multiple myeloma was coined in 1980. I don't know why Bob came up with it. It's a beautiful word, smoldering. It just conjures up the picture of something that's just waiting to happen. Something bad may happen, may not happen. We don't know for sure. And that's what it was. They had a few patients who looked like they have myeloma, a lot of bone marrow involvement, a lot of monoclonal protein, but years have gone by and nothing's happened. And these patients, they described in the New England Journal of Medicine in 1980, Phil Gripe and Bob, and said, like, this is not quite MGUS, this is not quite myeloma, we'll call it smoldering multiple myeloma. And it was important to define this because if you look at this, MGUS itself, MGUS has a risk of progression of only 1% per year. So you could reassure the patient and tell them, 10 years go by, you have a 90% chance nothing will happen. But smoldering multiple myeloma had to be teased out because the risk of progression was 10% per year. So you have a 50-50 chance of actually getting a cancer within 5 years. So he needed to make sure that patients understood the magnitude or the seriousness of the condition. And they arbitrarily defined MGUS and smoldering multiple myeloma the following way. MGUS means less than 10%, less than 3 grams, and no crab features. Smoldering means 10% or more, or more than 3 grams, and no crab features. And when you define it that way, that's the kind of split you get. MGUS has a 1% per year risk of progression. Smoldering multiple myeloma has a 10% per year risk of progression. And of course, as we know, crab features, the presence or absence of crab features is what defines myeloma from these two pre-malignant conditions. Now, the catch-22 is that since myeloma requires crab features, you're always waiting for the crab features before you can call it multiple myeloma. That means if you have a patient with a lot of bone marrow plasma cells, but no anemia, renal failure, hypercalcemia, or bone lesions, you're going to have to wait till one of those happens. And it's okay if the patient becomes anemic, but what if the first event of progression is a major vertebral compression fracture or a spinal cord compression or multiple pathologic fractures or worse still, acute renal failure? So if you're waiting for that to happen, then you're always going to make the diagnosis late. And so this catch-22 is the reason why we have then subsequently revised the diagnostic criteria in 2014 to include some of these very high-risk features and term them as multiple myeloma. Now, the revised criteria, just to make sure everybody is clear, basically made 3 additional myeloma-defining events. 60% or more plasma cells in the bone marrow, free light chain ratio of 100 or more, and more than one focal lesion on MRI, in addition to CRAB features, is now called as multiple myeloma. When you redefine multiple myeloma, you're automatically redefining smoldering multiple myeloma as well, because now you've taken some patients who would have been called as smoldering and reclassified them as myeloma. So what you see here is that smoldering multiple myeloma right now is 10 to 60%, more than 3 grams, and no myeloma-defining events. There's also one other thing that we added, which is a Bence-Jones protein or urine monoclonal protein of more than 500 milligrams. That's more than half a gram in 24 hours. And that was because Bob went ahead and studied this entity as well and published it in the very first issue of the Lancet Hematology, that when you have a patient with more than 500 milligrams per 24 hours of monoclonal light chains in the urine, without any other end organ damage, that is indeed not just MGUS, but smoldering multiple myeloma. So this is light chain smoldering myeloma. So this was the definition that we came up with. And one of the things that we have observed over the years that you have to understand is that smoldering myeloma defined like this, it's not some magical entity in between MGUS and myeloma. It's an arbitrarily defined condition. It's not an in-between stage where MGUS becomes smoldering and then smoldering becomes myeloma. It's an arbitrarily defined condition where some people have MGUS and some people have myeloma, but they're mixed up into that. And the clue for that came from the shape of this curve. So if you look at the shape of the smoldering progression, it's different from MGUS. MGUS is 1% per year, no matter how long it goes. You had MGUS for 20 years, the risk the next year is only 1%. But if you look at smoldering multiple myeloma, the risk changes over time. The first 5 years, it's 10% per year. After 5 years, from 5 to 10 years, the risk is only about 3% per year. After 10 years, the risk drops only to 1% per year. So what is happening is that if you imagine smoldering multiple myeloma as a mix of some patients with MGUS and some patients with myeloma, 50% of patients have MGUS, 50% of patients have myeloma. You don't know who's who. The myelomas don't have CRAB features, so you still don't know what to call them. They're mixed up, and that's what's in the smoldering bucket. 5 years go by, the myeloma patients develop CRAB and they declare themselves. And what you're left with is mainly MGUS patients. And so as time goes by, the risk of progression starts resembling MGUS. Now, this paradigm change is important because that is what led us to redefine multiple myeloma. What we asked then was, if only we can find out who these people are, then we can treat them early and leave the patients with MGUS alone till we have more serious things. So how do we define smoldering multiple myeloma today? We have to make sure one thing is clear. If you're taking patients with more than 10% bone marrow involvement or very high levels of monoclonal protein, either more than 3 grams in the serum or more than half a gram per 24 hours in the urine, you need to first exclude multiple myeloma. Excluding multiple myeloma means you have to exclude the usual things: anemia, hypercalcemia, and renal failure attributable to plasma cell disorder. Easy enough to exclude because it shows up on your laboratory evaluation. But as you heard from Elena, excluding bone lesions is not that easy. You have to do adequate imaging to be sure that the patient who you're reassuring that you don't have myeloma, you just have smoldering, needs to have a proper imaging assessment done for you to be sure that there is really no lytic lesion. That means today, either a whole body CT survey or a PET CT, and this was incorporated in the new criteria as well. Number 2, we need to make sure that they don't have any of the other myeloma defining events. That means they shouldn't have more than 60% plasma cells in the bone marrow. And I've just put some important points for you to note when you measure this bone marrow plasma cell percentage. Number 1 is make sure that the estimate is based on a regular H&E or right stain. not on immunostains or flow cytometry, because those can give you all kinds of wrong numbers. You need to make sure that that estimate is based on regular H&E or right stain, preferably bone marrow biopsy and aspirate, both need to be done, and you go with the highest value. If you see more than 60% in one or the other, then it's most like that is a patient with multiple myeloma. What about serum free light chain? Serum free light chain ratio, what we decided was that the laboratory, as you know, nowadays reports kappa over lambda. But for purposes of deciding whether or not the patient has smoldering myeloma, you're not going to do kappa over lambda. You're going to do high divided by low, because we think doctors may not know math that well. So that's why we decided we'll put the high number high and the low number down. And then if you get a value more than 100, well, that's in serious territory. So you take the lab value, whatever they're reporting, whether it's in milligrams per liter or deciliter, and do this yourself. And you're looking for a value more than 100. And you need to see, the patients with such a high value have a very high risk of progression, 80% over 2 years. And it's important to notice, and I'll give you some caveats here in a minute, but it's important to realize why we did the high free light chain ratio as a myeloma defining event. Number one, if you have a very high light chain ratio, it's an 80% risk of progression. Part of the progression events are renal failure. And that's the one, of all of the CRAB features, that's the one that really bothers me the most. Because once you have renal failure, the problem is it's not going to go away. This is a study of over 1,000 patients. The top line are patients with newly diagnosed myeloma who do not have renal failure at diagnosis. The bottom line, of course, are patients with newly diagnosed myeloma who have renal failure at diagnosis, but they never resolve. The middle is important. Once patients get renal failure, even if you reverse it, the prognosis never becomes the same. So it's really important in the new criteria that we look out for these patients with smoldering myeloma who have very high light chain levels and follow them carefully, because you want to treat them when the ratio gets more than 100, for the primary reason that if they do progress and they get acute Cas nephropathy, unless you're planning on seeing them every day, you are not going to catch that Cas nephropathy in time. It'll happen suddenly one day and it'll be creatinine of 7 or 8, and that's why we decided we need to treat these. When you do this, some of the caveats that you need to be wary of is that make sure that the light chain ratio is more than 100, but also the light chain level is more than 10 milligrams per deciliter or more than 100 milligrams per liter. It's because the ratio is a ratio, so it can be affected by the uninvolved. And so for some reason, if the patient has a very, very low uninvolved level, the ratio might look very high. So you need to make sure that the involved level is high enough. And that's why we put that criteria in. Number two, make sure that the 24-hour urine protein is done, and the 24-hour urine protein shows monoclonal protein of a reasonable amount. Why? Because sometimes these light chains can dimerize. And falsely, you can have patients with very high light chain levels, but nothing is going in the urine. Because the high levels are not just purely production, but it's due to biochemical dimerization, and these patients have very high light chain levels, but nothing in the urine. And you need to exclude those patients. And number three is, when the criteria were done in 2014, you may have had patients who have had high light chain ratios for 5 years or 6 years. Those are not the patients you want to now suddenly say, alarm them and say like, oh no, now we're going to call you as myeloma and treat you, because that's not the group we are focusing on. We're focusing on newly diagnosed patients where you don't know what is going to happen in the future. The third myeloma defining event is MRI showing two or more than one focal lesions, which is 2 or more focal lesions. You need 2 of them. And these are, as Elena mentioned, these are bone marrow changes. They're not lytic bone lesions, and they can be seen on the MRI even before the PET-CT or CT scan shows them up as lytic lesions, as you can see in this patient here. If patients have more than one focal lesion on the MRI, then they have a very high risk of progression, as shown in the study by Jens. Now, the important things to remember are that you need to be convinced that these are really focal lesions. Now, very subtle lesions people can get, and if you have any doubts, just don't call it. You need to be sure this is a lesion, and these lesions have to be a reasonable size, at least 5 millimeters or more. And if you have any doubt at all, just don't make the call. just repeat an MRI in 3 to 6 months. This is a study, a follow-up study in leukemia, and you can see here, these are patients who had, the black line is normal MRI at baseline, and 3 to 6 months later, nothing happened. They don't progress. Patients who had something on the MRI and nothing happened, they don't progress. But these are patients where there is a change in the MRI over time. Like it was 0 that became 2 or 1 became 3. Those are the patients that really progress. So any doubt on the baseline MRI, just wait and repeat an MRI, and you'll know who's the patient that you need to make the call that this is indeed myeloma and treat. So this is very, very important. I've shown this slide before. When we had CRAB features alone as the myeloma defining events, you will remember that we always said that you need to have CRAB features attributable to the plasma cell disorder. You need to be sure that the anemia is caused by the plasma cell disorder. Similarly, some amount of judgment is needed with the new criteria as well. You need to exercise judgment and not just blindly follow the criteria. Just make sure you're thinking out loud in terms of, is the free light chain really coming out in the urine? Is the MRI really a definite focal lesion? And so on. Now, in the next half, I want to just focus on some of the remaining patients with smoldering myeloma, the true smolderings that are left out. If you take 100 smoldering myeloma patients, the changes we made to the diagnostic criteria eliminate only about 10 or 15%. So the vast majority of smoldering myeloma patients are still smoldering multiple myeloma. And you can divide this group into 2 groups. The low-risk smoldering myeloma patients who have less than a 5% per year risk of progression, and the high-risk smoldering multiple myeloma patients who have a median time to progression of 2 years. That means a risk of progression of 25% per year. What Marivi and me and Sagar and Shaji and Philippe, what we worry about, who are